Hi, this is Elena Bergman, and I'll be presenting the Healthy People 2030 goal to increase the proportion of adults with diabetes and chronic disease who get ACE or ARB therapy. Healthy People 2030 states that diabetes and high blood pressure are the two main factors that contribute to the end-stage renal disease. Additionally, uncontrolled high blood pressure in persons with chronic disease can cause heart attacks, strokes, heart failure, and early death. Angiotensin-converting enzymes inhibitors, ACE for short, and angiotensin II receptor blockers, ARBs for short, or both drugs used to treat high blood pressure have been demonstrated in studies to lessen kidney damage in diabetics with chronic kidney disease. The objectives identified in Healthy People 2030 is to increase the proportion of adults with diagnosed diabetes and chronic kidney disease who receive recommended medical treatment with ACE or ARBs. And currently, only 43% of adults are using ACE or ARBs therapy, and the goal is to increase this number to 55%. ACE and ARBs therapy is the first-line treatment for hypertension and proteinuria management and shown to have protective effects on kidney and cardiovascular function in population with diabetes mellitus and kidney disease. The use of ACE and ARBs increased between 1999 and 2014. However, after 2003, the use of ACE and ARBs appeared to plateau for unclear reasons. In recent years, less than one-half of the chronic kidney disease population have been using ACE or ARBs, with the lowest number among people with preserved GFR. To increase the number of patients with diabetes and chronic kidney disease who use ACE or ARBs, it is important to understand the trends in the use of those groups of medications. In order to understand the problem, it's important to look at the prevalence of the conditions such as diabetes and kidney disease. According to the CDC, the number of Americans with chronic kidney disease is estimated to be more than 1 in 7, which translates into 37 million persons, or 15% of the population. Up to 90% of people with chronic kidney disease are not aware of their condition, and 25% people with severe chronic kidney disease are also unaware of their condition. Per National Kidney Association, Kidney Foundation, over 29 million of Americans have diabetes, and only 21 million of those people have a diagnosis. More than 51,000 new cases of kidney failure were caused by diabetes in 2013, and over 247,000 people are presently coping with diabetic kidney failure. It is estimated that 1 in 3 adults in the US is at risk for chronic kidney disease, and 1 in 3 adults in the US are estimated to have diabetes in the year 2050 compared to 1 in 10 today. Risk factors for the kidney disease include diabetes, high blood pressure, heart disease, obesity, and family history. National Institute of Diabetes and Digestive and Kidney Disease cites diabetes and hypertension to be the leading causes for the chronic kidney disease. Diabetic nephropathy, a common complication in people with type 2 diabetes due to microvascular damage to the renal blood vessels, is the leading cause for end-stage renal disease. Let's look at the problem significance. So chronically elevated blood glucose level in patients with diabetes potentially damage vasculature and nephrons of the kidney, leading to the altered kidney filtration function. The buildup of toxins and the accumulated water can cause the elevated blood pressure. Elevated blood pressure damages kidneys by narrowing, weakening, and hardening of the kidney's arteries. Insulin resistance is more common in people with hypertension, which increases their chances of developing type 2 diabetes. People with diabetes have significantly higher likelihood of developing hypertension as people without it. Given the magnitude and interrelation of diabetes and chronic kidney disease, it is vital to utilize all means of the prophylaxis and treatment of these two health issues. Use of ACE or ARBs is one of the crucial treatments that could be employed on a larger scale for prevention and treatment of chronic kidney disease in people with diabetes. Chronic kidney disease is a slow progressing disease, and numerous people are at risk for developing chronic kidney disease are unaware of the problem until the albumin is detected in the urine or their GFR declines. Research demonstrates a statistically significant delay in the initiation of the ACE or ARBs therapy, which affects the outcomes of the chronic kidney disease progression in people with diabetes. Let's look at the current treatment protocols for diabetic kidney disease. The number one recommendation is to control blood pressure, and number two recommendation is to control blood glucose. Other recommendation includes lifestyle changes and managing lipid levels. American Diabetes Association guidelines suggest starting ACE or ARBs therapy only when albumin is present in the urine or coronary artery disease is present. If there is no albuminuria or CAD, another therapy can be chosen. It could be ACE or ARBs, or it could be calcium channel blockers or diuretics. The American Heart Association and other professional societies guidelines suggest keeping blood pressure in diabetic patients at below or equal to 130/80. And the suggestion is to treat blood pressure to this goal. The treatment can be with ACE or ARBs, or it could be with calcium channel blockers, or it could be thiazide-like diuretics. There is no compelling evidence in favor of one drug class over another, except for the data supporting early use of RAS inhibitors in patients with overt proteinuria. Review of literature was performed using peer-reviewed articles written in the past 3 years. The search was performed using Google Scholar, Medscape, Cochrane, JAMA, Elsevier, and UpToDate databases, and the search words used were diabetes, hypertension, chronic kidney disease, RAS, ACE, ARBs, treatment management barriers, and current guidelines. So let's look at the trends in ACE or ARBs use in patients with impaired kidney function. According to Mortal et al., only 12 to 39% of patients with chronic kidney disease are receiving ACE inhibitor or ARBs therapy. According to Murphy et al., examined ACE ARBs use from 1999 to 2014 among 38,885 adults with impaired kidney function based on GFR or urinary albumin to creatinine ratio, concluded that ACE and ARBs were rarely used in those patients without the presence of concomitant illnesses like diabetes or cardiac disease. It was unclear why the plateau in the use of ACE ARBs has occurred. Chu et al. Assessed the prevalence and trends of ACE ARBs treatment among participants in the National Health and Nutrition Examination Survey with hypertension and albumin in the urine according to diabetes status. In a nationally representative sample, only approximately half of the US adults with hypertension and albuminuria were treated with ACE and ARBs medication, a proportion essentially unchanged from 2001 to 2018. And in Fried's et al. Retrospective analysis, the treatment initiation pattern were examined. after initial chronic kidney disease diagnosis among patients with diabetes during 2014 until 2018, and the study revealed that only 17% of the 15,400 patients without a history of ACE or ARBs therapy started such therapy within a year after meeting the chronic kidney disease criteria. Patients were less likely to begin the treatment if they were white, lived in the northeastern United States, had more comorbid conditions, and albuminuria that was not yet at advanced stage, or used sodium glucose cotransporter 2 inhibitors. This study identified barriers to ACE or ARBs therapy initiation, with one of them being education of the providers and the lack of their awareness with the guidelines. Another barrier is the guidelines themselves, which could be complex or not accessible. Some of the external factors served as barriers, including organizational constraints, such as lack of standardization of processes and procedures, time restrictions, heavy workload, and cost. And another factor was low patient awareness of potential disease outcomes. There was a concern about RAS inhibitors side effects such as hyperkalemia, and usually whenever hyperkalemia is detected, the treatment is discontinued. And another one is lack of albuminuria recognition by clinicians, or evidence-based medical care for management of albuminuria. And the last one is clinical contraindications of ACE or ARBs therapy in patients. This research found evidence-based benefits of using ACE and ARBs therapy. So the findings suggest that continued ACE or ARBs use is associated with cardiovascular health benefits in individuals with GFR below 30, without increased risk of progression to end-stage kidney disease. A high risk of death and the composite outcomes of cardiovascular death, myocardial infarction, and ischemic stroke after discontinuation of ACE or ARBs therapy in individuals who reached GFR of 30 was identified. Even though ACE and ARBs are associated with hyperkalemia, hypertension, and cough, therapy was still more beneficial in patients with non-dialysis chronic kidney disease stages 3 to 5. In this group, ACE was superior to ARBs and other antihypertensive medications for kidney events, cardiovascular outcomes, and all-cause mortality. And ARBs outperformed ACE in reducing the risk of kidney and cardiovascular events in patients with diabetic kidney disease. However, it lagged behind ACE in reducing the risk of all-cause mortality. Per model, the quality of evidence from randomized control trials on the effect of ACE compared to either placebo or standard of care on critical clinical outcome, such as all-cause mortality, progression of moderately to severely increased albuminuria, and doubling of serum creatinine from systematic review was considered as moderate. So the first study I chose for critique is titled Acute Increases in Serum Creatinine After Starting ACE Therapy and Effects of its Continuation on Major Clinical Outcomes in Type 2 Diabetes mellitus. The study it's based on the ADVANCE trial, which is a 2-by-2 factorial randomized controlled trial that evaluated the effects of blood pressure lowering and intensive blood glucose lowering treatment on vascular outcomes in patients with type 2 diabetes mellitus. The type 2-by-2 factorial RCT design is an experimental design in which there are two independent variables, each having two levels. This design can increase the efficiency of large-scale clinical trials. The study involved assignment of the combination of ACE and diuretic therapy to the participants versus placebo. Then the fixed dose of the medication was increased. An acute increase in creatinine was determined using the two measurements and classified into four groups. Increases in serum creatinine of less than 2%, second group 10% to 19%, third group 20% to 29%, and the last group is over 30%. Acute increases in serum creatinine after starting the combination therapy with ACE and diuretic was associated with greater risks of subsequent major clinical outcome. The primary study outcome was the composite of major macrovascular events, new or worsening nephropathy, and all-cause mortality. So clinical trials are a core aspect of experimental epidemiologic research and involve administration of test regimen to human to evaluate efficacy, effectiveness, and safety. RCTs are considered the gold standard approach for estimating the effect of treatments. The study sample initially involved 12,877 pre-randomized individuals with type 2 diabetes mellitus, aged over or equal to 55 years, at high risk for cardiovascular disease, who received a fixed dose of the ACE inhibitor, perindopril at 2 milligrams, and the diuretic indapamide at 0.625 milligrams. All other ACE were ceased, but ARBs were continued. 11,140 participants who adhered to the treatment were randomized into a fixed dose of ACE diuretic therapy and the placebo group. 2 serum creatinine measurements recorded before and during the active run-in period, 3 weeks apart. The dose was doubled 3 months after the randomization, and participants also received an intensive glucose control regimen aiming to achieve hemoglobin A1C at less or equal to 6.5%. The study sample was recruited from 215 centers in 20 countries. Large samples allow for a more precise estimate of the treatment effect, is more representative of the population, allows for generalization of the study results, and randomization of the sample minimizes sampling bias. The mean age of the cohort was 66 years old. 42.5% were females and 32.1% were males. All had history of macrovascular disease at registration, and mean eGFR value was 75. There were independent variables identified in the studies, which included the initial dose of ACE inhibitors and the diuretic, increased dose of ACE inhibitor and the diuretic, placebo, and the blood glucose lowering treatments, which included oral agents and insulin. And the dependent variables that varied depending on the dose of medication or the absence of the medication, placebo, were the serum creatinine levels, GFR, blood pressure, urine albumin to creatinine ratio, hemoglobin A1C, and the p-value was used to validate the measurements against the null hypothesis. The confounders were identified as calcium channel blockers, ARBs, prior use of ACE inhibitors, diuretic indapamide, and beta blockers. The statistical instrument used in the study was Cox regression model that was used to estimate hazard ratio and their corresponding 95% confident intervals relating to the level of acute creatinine increase to outcomes. This model is used to analyze the effect of several risk factors or covariates on survival, and it's commonly used in healthcare. The effects of randomized treatment on outcomes were assessed by unadjusted Cox regression model according to subgroups defined by acute increases in serum creatinine based on the intention to treat principle. Heterogeneity in the treatment effects between subgroups was tested by adding interaction terms to the relevant Cox models. So the data analysis used SAS. The data analysis was performed by using SAS and Stata software. Models were adjusted by age, sex, region, diabetes durations, chronic vascular disease history, cardiovascular disease history, smoking, drinking, BMI, hemoglobin A1C, GFR, cholesterol and triglycerides level, systolic blood pressure, and the urine albumin to creatinine ratio. Acute increase in creatinine was determined using the two measurements and classified into 4 groups discussed previously. This study concluded that acutely increased levels of serum creatinine after starting ACE therapy were associated with greater risk of major clinical outcomes. The findings suggested that while initial short-term increase in serum creatinine beyond 30% or even 20% are associated with less favorable prognosis, continuation of ACE inhibitors-based therapy in those who experience this level of increase may be beneficial and reduce the long-term risk of major clinical outcomes. The study suggests the benefits of continuing ACE inhibitor therapy for preventing clinical outcomes irrespective of the acute increase in creatinine. In other words, clinicians need to be cautious about discontinuation of the drug as it could result in unnecessary cessation of RAS blockade. The study strengths identified were the large sample, which derived from the international multi-center randomized controlled trial assessing the effects of the ACE and indapamide combination therapy, and evaluation of the relationship between acute increases in serum creatinine and subsequent major clinical outcomes using categorical and continuous assessments of serum creatinine change. And the study limitations included sample, which included participants with diabetes, and therefore the study results might not be generalizable to people without diabetes. Also, study is complicated by inclusion of the subjects who were already taking ACE inhibitors at the registration. And since the majority of participants had well-preserved kidney function, the assessment of the effect of continued ACE inhibitor-based therapy in patients who experience acute serum creatinine elevations of over 30 on long-term renal outcome was limited. The combination of the ACE inhibitor with diuretic was used and created the possibility that the diuretic could contribute to the effects observed in the findings. The second study for critique that I chose is titled Association between RAS therapy, discontinuation, and all-cause mortality among persons with low estimated glomerular filtration rate. So the study design, it is a retrospective propensity score matched cohort study. The cohort study is one of the most powerful observational designs used in epidemiology according to Frizerol. One of the main advantages is the efficiency of the research. The study analyzed the association between discontinuing renin-angiotensin system blockade after estimated GFR decreases to less than 30, and the risk of all-cause mortality, major adverse cardiovascular events, and the end-stage kidney disease in the subsequent 5 years. It is exposure-based study, and it's based on whether the participant discontinued ACE or ARBs therapy within 6 months after GFR decreased below 30. Study sample consisted of 3,909 patients from an integrated healthcare system that served rural areas of central and northeastern Pennsylvania. Patients who initiated ACE or ARB therapy from 2004 to 2019 and had a GFR decrease to below 30 were enrolled and followed up in 2019. The data derived from the electronic health records. The sample underwent rigorous selection. Initially, 162,654 individuals who initiated ACE or ARB therapy between 2004 and 2018 were identified. Next, the population was subset to the 10,810 individuals whose outpatient GFR decreased to below 30 after therapy initiation. The sample size underwent 7 rounds of exclusions based on the study's formal criteria and excluded another 6,901 participants. The individuals who stopped ACE or ARBs therapy within 6 months after a decrease in GFR to below 30 were compared with those who did not discontinue the therapy. The sample is large enough to provide more accurate estimate of treatment effect. Since the study is retrospective, it is not randomized, which may represent a selection bias, since the outcome has occurred at the time of selection. However, rigorous selection process minimized this possibility. The baseline dependent covariates identified in the study were the baseline serum potassium level, systolic blood pressure, and serum creatinine level at the most recent outpatient measures, available within 1 year before GFR decreased to below 30. And independent variables were ACE and ARBs therapy and discontinuation of ACE or ARBs therapy. The confounders were the baseline comorbidities such as stroke, heart failure, diabetes, coronary artery disease, concurrent use of medications such as statins, antiplatelets, or beta blockers, and the instruments used to analyze the data was the nearest neighbor propensity score matching, PSM for short, and it matched the individuals who discontinued ACE and ARBs therapy with those who continued on the therapy. So PSM is a quasi-experimental method used to estimate the effect of treatment and to reduce selection bias by equating groups based on covariates. The caliper used in the study was 0.25 per Wong et al., while 0.25 was a standard deviation caliper. The caliper width of 0.2 affords superior performance in the estimation of treatment effect. The study found no statistically significant difference in the risk of end-stage kidney disease, ESKD, but a greater risk of death and major adverse cardiovascular events associated with discontinuation of ACE or ARBs medication after GFR declines to less than 30. Similar patterns held for individuals with a 40% or greater decrease in GFR. The findings suggest that continuing ACE or ARB therapy in patients with declining kidney function may provide cardiovascular and survival benefits without excess risk of end-stage kidney disease. Multiple strengths were identified by the study. Number one was the use of propensity score matching method, which minimizes confounding and further adjusted for baseline demographics and clinical variables. The second was strengths was that several sensitivity analyses were used. A large population sample with a very particular characteristics was used, and the study evaluated a negative control and found that the two treatment groups' bleeding risks were comparable. And this conclusion lessened the worries that the reported increased risk of death and MACE linked with stopping ACE and ARB therapy would be a sign of worsening health among those who stopped ACE and ARB therapy. And the last strength was analyzing individuals who experienced a 40% or greater decrease in GFR within 1 year to address potential misclassification of advanced chronic kidney disease and to provide additional insights for clinics. And the limitations, first one, ACE and ARBs use was determined from prescription data. Thus, actual medication dispensation and consumption could not be confirmed. The second is study was observational and susceptible for unmeasured confounding. And intention to treat analysis gave an estimate of the effect depending on the initial treatment choice. And stage kidney disease itself is a treatment decision and likely varies by practitioner. And most of the study population was white. The recommendation for practice based on this research is to initiate treatment with ACE or ARBs in patients with diabetes, hypertension, and albuminuria. And these medications should be titrated to the highest approved dose that is tolerated to achieve at least 30% reduction in albuminuria, as this may be associated with lower chronic kidney disease progression and risk of kidney failure. Since RAS inhibitors are associated with an increased risk of hyperkalemia, monitoring for hyperkalemia within 1-2 weeks after initiation remains appropriate. Research results also support the continuation of RAS inhibitors even when patients experience an increase in serum creatinine, but close monitoring of kidney function is essential. So there are some research gaps that were identified in this study. Since the current recommendation for use of ACE and ARBs in diabetic patients is to initiate therapy only if albuminuria or coronary artery disease is present. The research is needed to identify the effectiveness of ACE or ARBs therapy in diabetic patients with preserved renal function to assess the prophylactic effect of ACE or ARBs in preventing kidney disease rather than attempting to slow down the chronic kidney disease progression. Currently, ACE and ARBs therapy is not recommended for Black population. Potentially reduced efficacy and limited outcomes data indicate that ACE inhibitors or ARBs should not routinely be initiated as monotherapy in Black hypertensive patients. This creates a pitfall for the Healthy People 2030 goal for the ACE and ARBs use increase. To conclude this research, the analysis of current trends in the use of ACE and ARBs and treatment protocols revealed some of the reasons for the plateau in the use of the treatments, including guidelines, providers and patients' education, lack of albuminuria awareness, therapy side effects, and their management. The indication of ACE-ARBs therapy initiation is the presence of the albuminuria in patients with diabetes and hypertension. There is no clear treatment protocols for prevention of kidney damage prior to albuminuria occurrence. The research indicated the absence of clear protocol for the kidney damage detection via GFR and albumin to creatinine ratios tests in individuals at risk. ACE and ARBs therapy is not appropriate for Black individuals with hypertension, therefore excluding a large population group from the Healthy People 2030 goal to increase the treatment with ACE and ARBs. The two studies reviewed in this presentation suggest that discontinuation of ACE or ARBs therapy in individuals whose creatinine levels acutely increase after the therapy initiation, as suggested by the current protocols, may not be beneficial. The increase in creatinine level points to the poor prognosis, and the therapy with ACE or ARBs may prevent kidney disease progression. It is necessary to provide close monitoring to those individuals to manage the potential side effects. A greater risk of death and major adverse cardiovascular events associated with discontinuation of ACE or ARBs therapy, while no statistically significant difference in the change of the end-stage kidney disease was observed. The Healthy People 2030 goal to increase the use of ACE and ARBs use in people with diabetes and kidney damage is widely generalized and need refinement. The current policies for initiation and discontinuation of ACE/ARB therapy needs to be reviewed. This is the end of my presentation, and thank you very much for listening.